I'm Cindy Francke, and welcome to Intraoperative EEG, Collateral Flow, Cerebral Aneurysm, Aortic Aneurysm, and Cardiac Surgeries. So this is basically going to be EEG 101 in the beginning here, and we're not going to spend a lot of time on it because I know there's a lot of EEG techs out there that are listening to this, but I want a little bit of an overview for those IOM techs that have never done an EEG so that they have a general idea of what we're talking about, and then they have a reference point. So what is EEG? We're going to talk about what is EEG, the definition and generation, frequency bands, head measurements and electrode placement, filters and settings, montages including different computerized EEG analysis, artifacts, drug effects, and the fact that you need a neurophysiologist trained in EEG to monitor. And one of the reasons you really need an EEG trained person for your oversight is that EEG changes can be so subtle that they can be missed. And if the person is not used to reading EEG, these changes may be missed in a timely not caught in a timely fashion. So what is EEG? EEG is recording the electrical activity of the brain. So every one of us sitting here listening to this has EEG going on. It's like the EKG for the heart. It's just much more complicated. It's electrical activity. It's a non-invasive way to study the physiology of the brain. So when I was working as an EEG tech, an MRI came and they said, oh, we're never going to do another EEG. We've got MRI. We can see what the brain looks like. Well, yeah, MRI shows what the brain looks like, but it doesn't show how it's functioning. So this is showing how the brain is functioning. EEG activity is very small, about 2 microvolts to maybe several hundred microvolts. The EEG frequency ranges typically from 0.5 to 30 hertz. That's the ranges that we are interested in on a clinical basis. This is a little slide that tells about the EEG generation from Wikipedia, and I'm not going to read through this. You can read this at your leisure. Frequency bands. We have alpha, beta, theta, and delta, and they're based upon the range of frequencies. So alpha frequency is 8 to 13 hertz. The amplitude or voltage is 50 to 60 microvolts. The topography is bilaterally synchronous, posterior dominant. It attenuates with eye opening and concentration, and it's a normal awake pattern. When you do EEG, the tech will give a technical description of the EEG, and they may say that the background activity of this patient is 9.5 hertz, which is the correct EEG speak, let's say. But I've had people say that the patient's alpha activity is 7 hertz. Background activity and alpha are not synonymous. Their background activity was 7 hertz, but that falls in the theta range. So do not use alpha and background activity. They're not synonyms. Just that the normal awake adult EEG, their background activity falls within the alpha frequency. And this is an example of just nice EEG going along, and you can see that this is about 1, 2, 3, 4, 5, 6, 7, 8, 9, about 10 and a half hertz, maybe 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Nice awake adult with their eyes closed. So here you can see there's nice EEG, nice background activity here. Patient opens their eyes, it attenuates, closes their eyes, and you can see the background activity reemerge. Beta, the frequency is 14 hertz and higher. The amplitude is fairly small, rarely exceeds 50 microvolts. The topography is anterior frontal or frontal central. It is non-reactive to eye opening and concentration. In an adult, it is a normal awake pattern. It's usually accentuated by the use of medications. And so generally, adults that have this pattern that is not being used, not on any barbiturates or benzodiazepines, things like that, their EEG is actually pretty low voltage even, and so we call it a low fast, and it's a normal variant, and you really can't see what their background activity is until they start to get a little drowsy. So here's an example of beta. You can see this is 1 second from here to here. So you can see that this is very fast. It's generally frontal central, maybe a little bit into the parietal, and the patient's awake. So theta, the frequency is 4 to 7.5 hertz. The amplitude is up to 50 microvolts, so it's still fairly low voltage. The topography is variable depending upon the patient's age and level of consciousness. So it depends upon if this is a pediatric patient, an adult patient, or a geriatric patient. And are they awake, drowsy, or asleep? It is non-reactive to eye opening and to concentration. It's considered normal in awake young children, awake elderly, and we have the definition is generally 60 years or older, and asleep, and during hyperventilation. It's abnormal in awake adults. Here's some theta. So you can see it just kind of looks a little slower. So if we look back here in the background, it's 1, 2, 3, about 4 hertz. 1, 2, 3, 4, 5, 6, 7 hertz. It's kind of slow. In a geriatric patient, this is normal. In an adult patient, it is abnormal. Delta, the frequency is anything under 4 hertz. The amplitude is generally high amplitude. The topography is generalized in sleep and during hyperventilation. Generalized in other states of consciousness, or if it's focal, it's abnormal. It's non-reactive to eye opening or concentration. So here's some delta activity. And we actually have a name for when it's frontally predominant, or only the frontal, it's FIRDA, frontal intermittent rhythmic delta activity. This is generally either from anoxia or it's a metabolic issue. So you can see this is 1 second here. You got 1, 2, 3. It's just low. It's high voltage. It's slow. The patient's awake, and how can we tell the patient is awake? Well, we have some muscle activity here in T4. So why do we measure the head? Well, we measure the head to provide a standardized placement of electrodes based on anatomical landmarks on the skull. It provides adequate coverage of the scalp in correlation to underlying brain area to ensure uniform placement, taking into the account of variations of head size and shape, so that the electrodes are over the same lobe of the brain on a child as they are on a full-grown adult male. It provides a standardized alphanumeric terminology based on anatomical correlates. Provides a consistent symmetry of electrode placement off of the midline, and to facilitate international communication in EEG. So 01 in the US is 01 in England, 01 in Italy, 01 in Canada, 01 in Brazil. So the standard electrode positions are based on 4 anatomical landmarks of the skull: the Nasion, which is that bump in the back of your head. And they tell me that the bigger the bump is, the more intelligent you are. So I've got a nice big bump that I like. The Inion, which is where your nose starts to take off. from your forehead. And then the left and right preauricular points or notches, those little notches in your ear. You use 10 and 20% calculations to for your electrode based off of these anatomical sites. And the electrodes are given names based on the lobe over which they lie, along with a number. So odds are on the left, evens on the right, and Z's or Z's for the midline. So here's the international placement. This is the left side. Midlines are Z's, right side evens. The electrode types that we use in the operating room, you can have surface electrodes. The pros, these are generally more secure than needle electrodes are. The cons, they need to be applied preoperatively. And if you're like me, you don't want to come in half an hour even earlier just to put electrodes on your patient's head. You need to prep the skin well. And that's not an alcohol wipe. That is taking like New Prep or Lemon Prep, one of those, and actually cleaning the area to lower the impedance. Needs to be securely applied with collodion, and generally with then a gauze square soaked in collodion placed over top of that so they stay secure. And they need to have electrode paste or gel needs to be added underneath the electrode so that they can conduct. It takes more time, that extra 30 minutes, and it's messy. You've got prep, you've got gel, you've got glue. You have to have a source for the air so that you can dry the glue. Is not very practical for intraoperative monitoring. Needle electrodes, on the other hand, the pros are they can be fast. You do it after positioning, and I always suggest people do it after positioning so that anesthesiologist or one of the nurses or somebody else in the OR does not get stuck. No skin prep is needed, no gel or paste. The downsides is you need to make sure that all the needle tips be facing the same way. So you all have to be placed towards the front of the patient's head or towards the back of the patient's head. One or the other, not towards the center, back or forth. They're not as secure as surface electrodes, as we all know, but I'm going to go over a couple ways that we can secure them. And we know that bleeding may occur. So this is a pre-bent needle electrode, and they stay in really nice. And I see people take the straight electrodes and bend them themselves and use them. The problem with that is that if that needle breaks and it breaks off in the patient's scalp, whoever bent it and placed it is going to be responsible. That's their liability. If they use ones that come from the manufacturer with this bend in them, then the manufacturer will be liable. And these aren't straight needles that they've bent. These are actually molded that way. So they have a 90-degree bend or a 30-degree bend or even a 45-degree bend. If you can't get bent needles, then you can do what I did in the very beginning when I started doing this, and I stapled the needles in. So I just took the surgical stapler and I stapled them in, and then use hemostats or Michelle clips to take the staples out. A little bit more blood, but my electrode stayed. We're going to talk about the amplifiers. So we use differential amplifiers, and we use this in EEG, and we use it in evoked potentials, EMG. It records the difference in voltage between two electrodes. That's all there is. In EEG, though, we have a polarity rule, and the convention is that negative is up. In SSEPs, negative goes up, N20. In auditories, negative goes down. And in visual evoked potentials, generally in the US, negative goes up and positive goes down. But in Europe and in the hospital I trained in, because our doctor was from Italy, our visuals, our positivity went up. The rule in EEG is if input 1 is more negative, relatively more negative than input 2, the deflection goes up. So on a number line, if input 1 is 30 microvolts and input 2 is 70 microvolts, so you have a 20 and a 70, the difference is 40, and it's going to be an upward deflection because input 1 is relatively more negative. So EEG techs learn this little polarity square. Our montages. You have bipolar, which is anterior-posterior, which is generally what is used in the operating room. It's also known as double banana. Coronal. So anterior-posterior is the front, recording from the front side to the back side, and it is left over right in the U.S. Again, in Europe, it's right over left with the midline between. Coronal is from front to back, so it goes the left front to the right front, then the left, like F3 to C3, so it's good to see from front to back. Anterior posterior looks at the difference between the left and right side. Coronal looks at the difference between front and back of the brain. We're generally interested more in the left and right side. There's referentials, so ear or any other non-cephalic reference or average reference. So this is just a setup here. You can see where things are plugged in. So this is the anterior posterior double banana. So you go left low chain, left high chain, midline, right high chain, right low chain. So somebody thought that these looked like bananas, I guess. So they called a double banana. And that's a double banana montage. But what's this down here? Left herbs to right herbs. I thought we were doing EEG. We're not doing SSEPs. Well, having the herbs running there, because you should have them in your SSEP montage, they're a great way of recording the EKG, because some of our patients that are short-necked, you'll get the EKG showing up in the temporal chain on the EEG, and this is a great way to prove that it is EKG, not EEG. This is a coronal. This is the front to back, so it's left to right, left to right, left to right, left to right. So it's good to tell the difference between front and back, but not between left and right. So why don't we use a referential montage? Because of artifact, interelectrodistance, and contamination. So if the reference electrode is producing artifact, it's going to show up in all electrodes, all channels. Interelectrodistance will be different. So if you're recording everything to the contralateral ear, so C3 is closer to A2 than T3 is. And so it can look like an amplitude asymmetry. And if you're getting EKG or just slowing in the temporal area, you're going to pick that up in the ear as well. So here is a couple examples. So here's contamination. This is CP3 to FZ, CP4 to FZ, OZ to FZ, EP1 to EP2. See how nice herbs? Gives you very nice EKG. So we've got this kind of slow thing going here. And especially if the patient's awake, you're going to get that. So you have contamination. This montage is C3 to reference T3, O1, C4, T4, and O2. And this is an artifact. And we know it's the reference because it's in every single channel. So let's look at a few EEG artifacts. This is cardiac artifact. So it shows up really nice here on the left temporal. We're pretty sure that it's EKG because it's fixed periodicity and the morphology, and it's limited to the temporal region. If they had an EKG on here, it would go boom, boom, boom. So people ask me, well, I don't have enough channels to run that herbs in there as well. Then listen to the anesthesia card, and you can hear it. It goes beep, beep, beep with the heart rate, and you can document it that way. This is 60 hertz, and 60 hertz in EEG looks different than it does in evoked potentials because of the time base. And in EEG, it's kind of hard to count because this is 1 second. You got to count 60 of these in 1 second. That's really hard. But basically, if it looks like a fuzzy caterpillar, in the EEG, you can pretty much guarantee that it's 60 hertz, especially if your patient's asleep. You know it's not going to be EMG. It doesn't vary. It's pretty steady. Here is 60 hertz, big 60 hertz, but wait a second, we're not getting it in the eye, so we know that this is probably 60 hertz. We're getting a little fuzziness, but not bad. So then they turn on the notch filter, and this is the exact same EEG, and now you can see it. In the US, we call it a 60 hertz filter. It's actually your equipment all will say notch filter because outside of North America, the rest of the world uses 50 hertz lines. So we always called it 60 hertz filter, and I'm old school. But on your equipment, it's notch filter. And generally in any of the software, you can change the notch filter from 60 to 50 hertz if you take your equipment, let's say, to Vietnam or India to do medical missions. This is outside interference. It was determined to be a walkie-talkie, but you will see this sometimes in microscopes and in the headlamps. But it has a really odd, it doesn't look like EEG. This is an electrode pop. The montage is C3, T3, O1, C4, T4, and O2. And which electrode is popping? Well, we know it's T4 because it's only showing up in T4. If it was the reference electrode, it would be in every single channel. Talking a little bit about computerized digital EEG, or it's raw EEG that is digitized, is all it is. This came up in the 90s. We started really getting into this. It's assigned a numeric value. It's a computer algorithm that converts the numerical values into a power ratio, which then is represented in a frequency line. And then you can display it in different formats. So it's taking the information and putting it into numbers. They say math can solve anything, and this is proof of that. So displaying the EEG, you always want to have traditional EEG displayed at the same time. And that's because of the computer saying GI, which is garbage in, garbage out. If you don't know what the EEG looks like going into that computerized, digitized EEG, what it's going to spit out is going to be garbage. You have compressed spectral array, CSA. There is density spectral array, DSA, and then spectral edge frequency, SEF. I'm going to talk a little bit about compressed spectral array, CSA. So it's a pseudo three-dimensional plot of EEG power. And this is what I like to look at because when they first brought out computerized EEG, all we had was CSA. So people are generally really comfortable with how they trained. I trained with CSA. So it takes hundreds of digital steps can be displayed in each graphic representation. So all these examples I'm showing you of the digitized EEG are the exact same example, just how it's shown. So this is CSA. So it's going between 1 and 30 hertz. So we know this should be about 15 hertz, halfway. About a quarter of the way should be about 7.5 hertz. So we can see a lot of activity here in 7.5 hertz. Everything's going into here. And this is the left, and this is the right. So DSA uses a color or grayscale to represent the EEG for each frequency. Generally, only 8 to 16 colors or shades are used, so it doesn't cover a wide range of power as CSA. And another problem is if the tech or the physician is colorblind. So I worked with a male tech who had colorblind, and he had red, orange, and green, blue color blindness. He couldn't see this. It was just shades of gray to him. So exact same time, this is, you can see there's a lot of stuff here about 7.5 hertz. And you got this spike, you've got some outliers. You're always going to have outliers. That's why you need to be running your EEG as well. So spectral edge frequency actually is the highest significant frequency present. So if most of their EEG is at 6 hertz, that's what's going to show. So it's usually set to 90 to 97% of the recorded EEG power. And a decline in SEF suggests an overall frequency slowing. So that the spectrum is shifting to lower frequencies. And we use it a lot in carotid endarterectomies. So exact same thing. And here you can see, this is pretty straight, but you've got this outlier here. Well, with the DSA, it lines right up there. So if we had the running EEG, the traditional display, there's probably an artifact right there. And you get artifacts out here, and that's normal. But you can see it's pretty much a straight line. It's going up and down. It's not starting here and declining down to here. Oops. And you can actually, in some software, you can actually have the number here, the SEF. So drug effects on EEG. We're not going to go over these in great detail because I cover it more in the anesthesia talk. But you need to know these. Some of the physiological effects. So if it affects your EEG, it's going to affect your SSEPs and your MEPs as well. Your cortical SSEPs and your MEPs. So that's just something to remember. So the patient's core temperature, if it's above 32.2 centigrade, no changes. If it's 30 to 22 degrees, there's going to be significant slowing. Arterial blood pressure, if it's above 80, the map is above 80, there's not going to be any changes. Below 80, it may become isoelectric. So we've all been in there where the surgeon says, I've got the patient's bleeding, lower the blood pressure, and the anesthesiologist takes them from 80 down to 70 map. You're going to have a hard time getting the MEPs. You're going to have a hard time getting your cortical SSEPs because your EEG has slowed. So it's another nice reason just to run EEG during spine cases. They may get them into burst suppression. So here you have a burst and then suppression, burst. This is a little bit better EEG. They're bursting with slight suppressions. This is isoelectric. So when the map is dropping below 80, you may get these, and we know this is iso. It's like, well, but hey, there's something going on here. Well, it's in every single channel. It's even in the same posterior and anterior. And if the EKG was on there, you could tell that this is EKG artifact. I got in. Oops, sorry about that. We're going to talk about the collateral flow now. Out of the EEG stuff into real life. Collateral flow is just an alternative circulation via another pathway, such as neovasculation. And an example of this is choroidal neovasculation, which is the creation of new blood vessels in the carotid layer of the eye, which is a common cause of neurovascular degeneration, myelopathy. So the body has started making new pathways. You have a pre-existing vascular redundancy, which is the body has a backup system. And what we are mostly concerned about of the pre-existing vascular redundancy is the circle of Willis. So this is a picture of the circle of Willis. It has all the names of all the arteries and all arteries that come out, every little thing. It's interesting in that 40% of elderly patients do not have an intact circle of Willis. The circle of Willis was named after Dr. Thomas Willis from the 1600s. So we've known about this for more than 4 centuries. This is the classic picture, but according to Bergman's 2005 Illustrated Encyclopedia of Human Anatomic Variation, Opus 2, Cardiovascular System, Arteries, Head, Neck, and Thorax, on 34.5% of the population have a classic anatomy. Only 34.5, just over a third. And this was based on a study of 1,413 brains, and they came up with 83 different variations. This is Circle of Willis, and this is taken from Clinical Neuroanatomy Made Ridiculously Simple by Dr. Stephen Goldberg. I love this book. So this is Willis the spider. And he's either fat because the pons is his belly, or he's skinny because his basilar artery is laying on the pons. He's got fuzzy armpit. He needs to shave his underarms because that's cranial nerve 3. He's got a major V unibrow going on here. That's the chiasm. So it's just kind of nice to remember this so that you have a general understanding. This picture has every little artery and arteriole that comes out of it. This is the basic structures. So this is Clinical Neuroanatomy Made Ridiculously Simple. It is $24.95 on Amazon. This is I've had to buy this book 3 times because my other 3 or 4, maybe even 4th time, my other copies have grown legs and walked away. So I'm not bringing it anymore, even when we have these in person, because they just go away. $24.95 for a book, and believe me, I wish I'd had this book when I was studying for my boards, because for the neuroanatomy that we need to know for boards and for doing our job, it's almost 100% there. So the brain is an energy hog. It's only 2% of our body weight, but it takes 15% of the cardiac output, 20% of total body oxygen consumption, 25% of body glucose utilization, with a third of that going for the sodium-calcium pump. Cortical gray matter has 3 times the energy requirement than cortical white, and some cortical gray matter has 2 times the energy requirements of subcortical white. This is just a really nice little diagram showing the cerebral fusion. So with the map and cerebral blood flow here. And when the cerebral blood flow drops and the cerebral pressure goes, the map drops, you can see that the EEG starts to slow, it gets flat, membrane failure, and you also see what is happening to the neuronal process. So this is normal neuronal function, dysfunction viability, you're starting to get some delayed neuronal death, rapid neuronal death. So neuromonitoring for vascular procedures. EEG, 1 to 70 hertz, 1 to 50 hertz if 60 hertz is present. You can use the notch filter on EEG, unlike you should not on evoked potentials, because you'll get a phase shift. EEG, we turn the notch filter on all the time. If I'm running a Cascade 16, I'll run 1 to 50 hertz, because if you turn on the notch filter, it eats up your processor. So any of the older equipment need to be, whether it's ours or another company, you need to make sure that it doesn't take up your processing. Settings, you want your input gain to be as sensitive as possible, display gain as you needed. In our surgical studio software, The time base is 100 milliseconds per division, which is what we're used to. So each division is 1 second. Or on classic, that is waveforms drawn at 30 millimeters per second. That's what you're used to looking at EEG. Sleep people, and if you're looking for slowing, you might want to take that down to 10 or 15 millimeters per second because you want to squish it, because when you squish the EEG, the slow waves are accentuated. SEPs on these, you're going to use the exact same montages. Same with any cranial nerve or EMG you're going to use. Same. Same with your motor evoked potentials, except that you really only need the hands and the feet. Brainstem auditories, normal montage. Carotid endarterectomy. So it's a procedure to remove plaque buildup from inside a carotid artery to restore normal blood flow. It is done for moderate 50 to 79% blockage in a symptomatic patient or 80+ percentage blockage in asymptomatic patients. So these symptoms will include strokes or TIAs. Does anybody only have a carotid occlusion on one side? No. When the patient's having issues, or they will do some scans and see, and one side might be 70% blocked and one might be 90% blocked. What side do they normally operate on first? Well, they normally operate on that 90% side first because they know there's not a lot of blood flow getting through there, so that 70% is probably letting some collateral blood flow come through. So they want to maintain that, so they'll do the worst side first. And it's performed generally by vascular and neurosurgeons. I find mainly we're used more for neuromonitoring by neurosurgeons than vascular surgeons. And this is just what they're going to do for a carotid endarterectomy. You can go to YouTube and actually see these surgeries. This is placing a shunt. This is just taking out the plaque. So this is, shunts don't always prevent strokes. You can get a tear. And to shunt or not to shunt, that is the question. So there are shunters, and they shunt to ensure blood flow. And want to make sure there's blood getting flow through there. But as we already said, shunting has its own issues. Non-shunters to decrease emboli because you can throw plaque during shunting. And then you have selective shunters who base it on vascular and neural monitoring. So they'll clamp it and they'll ask us what we see, and if we're good, then they won't shunt. If we have a change, then they'll shunt. So the changes in EEG will be in both frequency and amplitude. 10 to 30% of the patients will have a change. 80% within 1 minute of clamping. 69% within 20 seconds of clamping. So here is complete or partial loss of all activity. So the cerebral blood flow was only 38, which is pretty low. But there's EEG. They place the clamp. This is 6 seconds here. So this is about maybe 15 seconds, less than 20 seconds. And you can see that the left side has no blood flow to it. The EEG has just almost completely disappeared. The cerebral blood flow was down to 2. So they went from 38 to 2. You can get a mild loss of fast activity and minimal increase of slower activities. So this is way back in 1979. So we've been doing this a long time. So 65-year-old man, left carotid occlusion, right carotid stenosis. So the left's occluded. I'm going to assume they're doing a left carotid. So before clamping. It's not great EEG, but this is his baseline. The CBF is 71. 40 seconds after clamping, you can see that there's complete change on both sides. Cerebral blood flows down to 13. They put a shunt in. Cerebral blood flows back up to 46, and you can see it's back to baseline. It's still not great EEG, but it's back to baseline. That's what we're looking for. So cranial nerve monitoring. During carotid endarterectomies, cranial nerve 10 to 15% of the patients will have vocal cord paralysis, usually transient. Can last 3 to 36 months. So they can talk, but they can't project. So imagine for a few months talking like this, that you have no projection. And then by the end of the day, it gets even worse and worse and worse. You use the specialized endotracheal tubes. So here's the 1 and 2 channel tubes. There's some new ones that are on the market that are a 3-channel now. If you don't have the specialized tubes, you have electrodes on standard endotracheal tubes. This is a 1-channel. There's a 2-channel. There's also pediatrics. SSEP. So median nerve, 11.3% have significant cortical channel changes. So this is from the blood flow. The subcortical channels have stayed, and peripherals have stayed steady. Median nerve changes are according to the diagnostic value of somatosensory evoked potential changes during carotid endarterectomy, a systematic review and meta-analysis, and this was done at the University of Pittsburgh, 4,557 patient cohort, and Dr. Jeff Balzer was the second author on this. So if any of you know Jeff, he'll talk your ear off on this. Posterior tibial nerve SSEPs, 20.2% have significant cortical channel changes. Well, that's almost double. Why do we do median and not post-tib? Well, trying to get post-tib SSEPs, we know can be really difficult. And so median nerve is much easier, and we're used to looking at it. Posterior tibial nerves, trying to get those on these patients aren't always the easiest thing to do. These PTN changes were according to limitations of median nerve somatosensory evoked potential monitoring during carotid endarterectomy in Japan. So there's a new way of doing carotid endarterectomies. It's called transcarotid artery revascularization, or TCAR. And this is a new procedure for treatment of carotid stenosis, and it's by Silk Road Medical. And their website is www.silkroadmed.com. Right now, there's approximately 250 medical centers utilizing this procedure around the country. I've seen it done. So it's a small incision just above the collarbone to expose the common carotid artery. And there's a soft, flexible sheath placed directly in the carotid artery that is connected to a system that reverses the flow of blood away from the body. The blood is then filtered and returned through a second sheath placed in the femoral vein to remove emboli. Then they can get in there with balloon angioplasty and stenting to perform during blood flow reversal. And a stent is placed to stabilize the plaque in the carotid artery. So they don't really clean it out, they stabilize it. The flow is reversed and then turned off. So I'm going to give you some statistics of TCAR versus carotid endarterectomy, and I'm doing this because I think you're going to see more and more surgeons using this procedure. So TCAR versus CEA. Stroke for 30 days, TCAR 1.4%, CEA 2.3%. Cranial nerve injury rates, TCAR is 0.5%, CEA 5.3%. most likely because these TCAR comes from, most likely I would think from the intubation, not from the surgery, because the incision is way far away from it. You're not going to get near cranial nerve 10 there. Though the cranial nerve injury unresolved rates at 6 months is TCAR was 0% of unresolved and 2.1. So you can see that 2.1% of the patients still have transient vocal cord paralysis at 6 months. The efficiency is TCAR, it takes about 10 minutes for the reverse flow time, and CEA is 30 minutes worth of clamp time. Again, you're going to see more and more surgeons using this. The neuromonitoring modalities I'm going to offer are what I saw based on what is done at Hitchcock Dartmouth in New Hampshire, and they do several of these a week. So you're going to do EEG, and they do median nerve SSEPs. The changes are going to be the same that you'd see as for a carotid endarterectomy. An aneurysm. So an aneurysm is a weakening of an artery wall causing a bulge or distension. So us that go back when we were kids and we would take the inner tube out of our bicycle tire and you could see that bulge and you just knew that you were going to get a blown tire. Basically, that's what an aneurysm is, but it's in a vessel in your brain. Many symptoms are mild and asymptomatic, and generally those symptoms are found, these aneurysms are found incidentally at autopsy. So don't have your mom and your grandma's rushing out to have one of these total body scans to see if they have anything. They might have an aneurysm, but they're not having any symptoms, so it should be just fine. Leakage or rupture can cause severe headaches or strokes and stroke-like symptoms. So it might be numbness or weakness on one side of the face, dilated pupil, or vision changes. So we'd ask them the same things that we'd ask if we thought Uncle Albert was having a stroke. It's not up to us or a family member to decide, was this a stroke or an aneurysm? Both of them are a loss of blood flow to the brain, so get emergency help. And they're treated with clipping or coiling. So this is kind of where most of the aneurysms occur. So 40% at the anterior communicating artery. Middle communicating artery, 24%. Here at the posterior, 20%. Posterior cerebral, 4%. So most of them are going to be right here or right here. An angiogram. With an aneurysm, you don't ever have had to look at an angiogram or have been taught how to read it to know this ain't right. There's something missing. Something's wrong here. That's that bulge in the inner tube. So this is just circle Willis here, aneurysms, and where you might do SSEPs or MEPs. These aneurysms, you might do brainstem auditory vocal potentials added to it. Just another view of it, that you want to do motors and you want to do SSEPs. Pretty much looks the same everywhere, doesn't it? This is run EEG on all aneurysms. I always run EEG. And this is a really good slide if you're going to be taking your boards, because especially EEG, they don't ask you, your anterior, they have had a stroke in the middle cerebral artery. What part of the brain does that feed? They'll give you the symptoms and then ask you to name the vessel. So this is a little bit easier to look at. The cerebral artery territories, this is the anterior. So if it's an anterior, you want to do the leg in there. You want to do those nasty post-tibs. Middle cerebral, arm and hand. Posterior region. You could try visuals. It doesn't really work. I'm not a big advocate of visual evoked potentials. I know people that get them remarkably well, but the anesthetic regime and such is very, very strict. But we know that all of these kind of overlap on each patient. So, unless their symptoms are way down here, maybe in the face on your upside down man, you might want, if it's up here on the arm, or the thumb, you might want to throw in the leg just in case. So the EEG, neuromonitor, SSEPs, motor evoked potentials, and possibly brainstem auditories. So here is that it's another EEG with the spectral edge frequency. So this is at 90, this is right here. This is burst suppression. So sometimes the surgeon will have them put into burst suppression so that it's a neuroprotective for the brain. So you got suppression, burst, suppression, burst, suppression. And this is at 90%. That 90% means that 90% of it is in suppression, and there's 4 bursts per minute. This is SSEP changes from upper extremity SSEP during a carotid, but it'll be the same thing as for an aneurysm. And this is old because it says SER, so somatosensory evoked response, which was really old nomenclature. This is, again, 70s. So this is the procedure. So their patient's baseline, nice and 20. They're alert. They clamp. Patient is dazed, non-responsive, twitching right face, and you can see a degradation of the waveforms. 2 minutes of clamping gets worse. Patient's the same. They place a shunt. Patient starts to recover. The SSEP recovers. 4 minutes after shunt placement and just before removal, beautiful. Patient's alert, counting, naming, moving fingers and toes. 2 minutes of clamping for shunt removal after repair. You can see it degraded again. Patient's dazed, non-responsive, and aphasic. Take the clamp off. Within 4 minutes, everything's back to normal. Both SSEP and patient had alert with no neurological deficits. MEPs. These changes will occur when the temporary clip is placed, the retractors are placed, or the permanent clip is placed. So when the temporary clip is placed, you let them know and ask them to reopen the clip to allow reperfusion. And they're going to have to keep the clipping as short as possible. Retractors placed. This is going to be generally because it's on the internal carotid artery. So you ask them, did you just clamp? No. Did you just do something? Did you place retractors? Yes. Well, it's usually on the internal carotid artery, and you ask them, could you just reposition the retractors just a little bit? And they're going to do it. You're not going to get the response, no, I can't. They're going to try to move things around as much as possible. If the changes occur when the permanent clip is placed, then they're going to bring an ultrasound, make sure that there's blood flowing through there. Might need to reposition the clip. To do auditories, when you do auditories, it's aneurysms arising from the basilar or vertebral arteries, but we saw that that is only like 4%. But you'll get a 50% decrease in amplitude in wave 5, 10% increase latency in wave 5, and a 10% increase in the interpeak latency waves 1 to 5. Aortic aneurysm. So there's 3 types of aortic aneurysms. There's ascending, descending, and abdominal aortic aneurysm, and those are the most common. According to the CDC, there were 9,928 deaths in 2017 from aortic aneurysms. 60% of those deaths happen among men, and 75% of all the patients have a history of smoking. So here's just where they are. So here is an ascending thoracic aortic aneurysm. Here's a descending, so it's going up. This one's going down, and here's an abdominal. And if you've ever seen one of these bleed, it's not good. So neuromonitoring, we're going to do EEG, SSEPs, and motor evoked potentials. Why motor evoked potentials? Well, you're going to cut off the blood supply and you're going to have an ischemic event. So cardiac cases. There's neurological monitoring types are clinical. This is done on all cases, and it's arterial blood pressure, central venous pressure, cardiopulmonary bypass, arterial oxygenation, temperature, hemoglobin concentration, pupil size, and arterial partial pressure of carbon dioxide. Why are these done on every single case? You've got an anesthesiologist that's doing all this. So it doesn't have anybody else in the room, nothing that they're not already doing. Neurological monitoring types of cerebral activity. So you'll use EEG, SSEP, MEPs, brainstem auditory evoked potentials. It's not used as commonly in the past. I used to do several cardiac cases back in the 90s and early 2000s. Most of the problems with ours is because of the invariable fall in core temperature and pharmacological effects. So they'll be used if the surgeon wants to put the patient in burst suppression. I did a case where they put them on the heart-lung bypass. So they wanted them in burst suppression, and they wanted to know exactly how much. My SSEPs and my MEPs would have been useless then. They might use SSEPs when they think there's going to be a positioning issue. So again, they're looking at a brachial plexus injury or something in positioning, the same thing that they use this for in spine cases. Motor evoked potentials could be used in possible positioning issues or in spinal cord infarction. And since SSAPs and MEPs are affected so much by the amount of cerebral activity, if they put them in the burst suppression or into isoelectric, then the responses are going to be lost. But the subcortical SSEP responses, as well as auditory evoked potentials, they're much less affected by core temperature, and they're also less affected by anesthetic regime. So, and they're known to be present even in the absence of suppression of cortical activity. So why don't they use us more? Well, it's an additional specialized personnel and equipment. These cases take a long time, but it's another person in there. It's another expense. But I'm seeing more people doing them again recently because a lot of these cardiac patients post-operatively are obtunded or comatose. And so then they go into the ICU and they find out that they had an anoxic event, and they might get put into ICU EEG monitoring, and that increases the cost between the monitoring and the extended stay in the hospital. So if you have any questions or want any of these references, just drop me an email at cindyf@cadwell.com. Thank you.